My topic today is calcium inhibitor-free immunosuppression in kidney transplant recipients from elderly donor. So the topic is dealing with the two things. One is like a CNIF immunosuppression, and second thing is what to do when we are receiving organ from the elderly donor. So do we need to have like some sort of different type of immunosuppression when the donor are elderly? So first we see what is the impact of donor age on graft and patient survival. So we don't have like a big data from India. So I think in my presentation, the most of the data is from the Europe or USA. So we can see is like a high donor age is one of the strongest risk factor for the outcome. And what we can see is as the donor age increases from like 18 to 30 years to progressively 60 years, 65 years, 70 years, progressively the death and the graft survival decreasing. So the older the donor, the poorer is the outcome in terms of graft survival. But still, if you see, there is a lot of organ shortages. So if you see, like this is a data from the CTS Europe study, what we can see is in the last 25 years, progressively the age of the donor is gradually increasing. So previously, in the like 20 years back, more than 70 years was only 4% donor. In the last 10 years, almost 50% were of all donors were like more than 70 years. So progressively the age of the donor is increasing, and so the recipient age. So previously we are not offering the transplant to like more than 65 or 70 years patient. But now what we can see is in the developed country, almost all 10 to 15% transplant recipient were like more than 70 years. So there is like a more than now the age of donor is also increasing, age of recipient is also increasing, and so I think the theme is like many times the older kidney are offering to the older donors, mainly in the term of like a disease donor transplant setting. Now, why the old kidney has like a poor outcome? So what we can see is there is a lot of changes occur in the kidney in terms of like a microscopic changes, like there is an increase in glomerulosclerosis, intercellular fibrosis, vascular changes, arteriosclerosis, tubular atrophy. So these are all these things that ultimately transition to decreasing GFR, decreasing the functional capacity, decreasing the autoregulation. So all these things that ultimately lead to decreasing graft survival with the aging kidney. Now, what is the impact of when the donor age is high? So what we can see is as compared to young donor, in the old kidney, they will have a more immune activation, particularly in the setting of the disease donor transplant. They will have a decreased tolerance to ischemia for the injury. They will have a defective renal repair mechanism, and they will have excess of vasculopathy. So the older kidney, they will have a more inflammation, they will have a more vasculopathy, they will have a very less functional reserve, and the capacity of repair is very much limited. So basically, the older kidney will ultimately give poor outcomes. In that same terms, if you see the like a particularly disease donor transplant, the most of the older kidney will go to the older recipient, because the most of the like a young patient, they are not that much willing to accept the like a old kidney, like particularly like a more than 65-year-old kidney. So what the things changes in the old recipients. So what we can see is in the old recipient, with the time the immune senescence occurs. So there is like a decreasing T cell response, decreasing B cell response. So ultimately the rate of rejection will be less in the older recipients. Now this is like a data regarding the disease donor transplant. So what occurs in the living donor transplant? So this is like one of the paper from USA suggesting a US RDS data. So what they have suggested is in the living donor, if the age is up to 65 years, the outcome is usually very excellent. The donor age up to 65 doesn't matter much in terms of the like a graft survival outcome. But when after 65 years, like 70 years, 75 years, there is a significant decrease in the survival when the living donor transplant donor is more than 65 years. So coming this mind, we can have like a different recipient donor combinations. So my theme is like an old donor. So in the old donor, we can have like an old living donor and like an old disease donor. We can have like a different terminology of like old donor. In the West now they have like a more and more relaxation. So now in the West they are defining old like a more than 70 years. But I think in our country, I think like a cutoff of 60 or 65 years will be more appropriate to define whether it is young kidney or old kidney. So in the elderly donor, we can have a elderly living donor, we can have a elderly disease donor, and the recipient may be young or old. So we can have like a different combination. So we can have like a elderly living donor with young recipient, elderly living donor with old recipient. Similarly, we can have a elderly disease donor with young recipient and elderly disease donor and old recipient. So like we can have a different combination of like a old kidney living or disease with the, like a different type of recipients. So if you see in the practice, like what type of this combination that we see in practice. So in the practice, what mainly see is like we see in the elderly living donor is like a mostly where like a parents or grandparents are donors. So like most of the time they are like a age is like a more than 60-65 years, or many times the grandparents are donor. So in such case, what we can see is we can have a very young recipient and we can have an old donor. And very rarely in our practice, we see the spousal old donors. So in the our practice, what see main elderly living donor are basically like a parent or grandparent donors. And in the elderly disease donor, like what we see is like most of the disease donor kidney, particularly if it is like an expanded donor kidney, the most of the time the young patient are usually refusing to accept this kidney unless they are waiting for a very long time. So in the elderly disease donor transplant, particularly ECD kidney, the most of the recipients are usually elderly recipients. Now coming to the what different age recipient age donor combination have impact on the outcome. So here on the left side, this is basically data from the disease donor transplant data. So what we can see is in the left side, the recipient age is 18 to 65 years. So what we can see is that there is an impact of donor age. So if the donor is increasing, even in the young patient, the outcome changes. If the recipient age is more than 65 years, then even then the donor age has impact. So if the old recipient received a younger kidney, it has a better outcome than receiving the old kidney. Now coming to the second thing of topic, why we want CNI-free immunosuppression. So what we can see in the last 25-30 years, in the left side we can see like a changes in the acute rejection rate by the different era. So what we can see is by the introduction of cyclosporine, so subsequently mycophenolate, mofetil, tacrolimus and induction agents, what we can see is from 90s to 2000 there is a significant decline in the acute rejection rate. So it has declined from like more than 20% to like almost like 8 to 10%. So first year rejection rates are very low, but if you see that in terms of the long-term outcome has remained static basically. So why the decrease in the acute rejection is not lead to improved graft survival, particularly after 1 year. So this is basically because of a lot of other causes, like in the late allograft failure, we can have like a late cellular reaction, late antibody rejection. We can have even non-immune factors, like we can have a CNI toxicity, we can have a recurrent disease, de novo disease, infections, death with functioning graft. So because of this all factor, despite such a reduction in the acute rejection, the long-term outcome has not improved significantly in last 2-3 decades. Now coming to the how common is the CNI toxicity. This was one of the very landmark paper by Dr. Brian Nankival. Well, they were looking for the protocol biopsy every yearly for 10 years. So what they found was after 5 years, the rejection rates are very low. But what we can see on the right side, the CNI toxicity become universal. And what we can see after 8-9 years, it is almost present in all grafts. So it is almost like present in 80 to 90% at the end of 8 or 9 years. So CNI toxicity is a universal in the long term. So then we may have some way to minimize this toxicity. Otherwise, this toxicity is going to be a very important cause of late allograft failure. So coming to the question, is the older kidney are more susceptible to CNI nephrotoxicity, because the theme is like old donors. So yes, the CNI older kidney are more susceptible to CNI nephrotoxicity because there is a age-related changes in the autoregulation. So older kidney will be less able to maintain autoregulation. So there will be excessive vasoconstriction in response to CNI exposure. There will be age-related changes in the preglomerular vasculature. So this will ultimately lead to more glomerular ischemia with CNI exposure. Or also there will be a senescence of renal tissue with impaired cellular repair. So such kidney will not be able to have a much repair mechanism when exposed to CNI. And there are also some thoughts the CNI may accelerate the cellular senescence in the old kidney. So because of all of these things, the older kidney are more prone to have a CNI toxicity as compared to younger kidney. So, but if you see the like a practice data, so this is like a practice of USRDS data. What we can see is like 60% patients are on the prednisolone, tacrolimus and morpholate, and rest of patients are like a steroid-free patient on tac and steroid. Very almost like a less than 10-15% patients are off CNI basically. So why the CNI is standard of care? Despite we all know their CNI toxicity is very common. So why CNI is standard of care? Because of the lot of study. I am quoting just one study. This is like a Elite Symphony study. What it suggested, it tried to compare like 4 arms. like a low dose mTOR inhibitor sirolimus and with like a standard or low dose cyclosporine or low dose tacrolimus. So what is found is the least amount of acute rejection is with the low dose tacrolimus, and the highest amount of biopsy prone rejection is with the low dose sirolimus. So ultimately, the problem with the non-CNI is a very high acute rejection rate. They offer like advantage of like a less CNI nephrotoxicity, but that is offset by the high acute rejection rate. So because of this thing, the CNI is still not a standard of care in the most of the protocol, even in the with the old patients. Now here we are trying to like, can we offer like a non-CNI exam in the old patient, because all this trial, like Elite Symphony trial, if you see the mean age, it was like a 45 plus or minus 15 years. So the most of patient like age was like less than 65 years. So can we offer like a non-CNI exam in the old patient, considering they will have a less acute rejection? So basically the elderly will have a less immune competence, so they have a less chance of rejection, and this is basically supported by less rejection, acute chronic rejection, high complication. But the problem is the kidney, if the most of the old patients are receiving kidney from the old donor, so like it has very less margin reserve. So if they get a rejection, the ultimately graft loss will be much higher if they get rejection. So coming to the like, what is the data of like an old donor? So here's the data. What we can see is like this is on the lower side. This is like a recipient age from 1829 to like more than 65 years. So what we can see is like as the age increasing, there will be a lesser acute rejection, but there will be more infectious death basically. Coming to the relative risk of rejection and death, what we can see is if the age is more than 65 years, they will have almost like a 30 to 40% less risk of rejection, but they will have almost 6-fold high risk of infectious death. So we will have try to have the regimen with like which will be less nephrotoxic, will have overall less immunosuppression burden, because in the old patient the biggest problem is like a death with the functioning graft. So coming to like so in the ECD kidneys, the most of the recipient will be elderly. So in this cases, the tailored immunosuppression is very important, because such kidney will have like a poor function, increased risk of like a CNI toxicity, increased risk of infection, severe risk malignancy, and ultimately there will be a long DGF, long hospitalization. The cost will be very high. So what we can do to avoid CNI? So there are like a different type of strategy. Like it can vary from CNI avoidance to CNI withdrawal to CNI conversion to CNI minimization. So CNI avoidance means like we don't give CNI from the beginning. So it is like a de novo non-CNI regimens. So we can have like a different strategy. Like we can give like a steroid morpholate, steroid mTOR inhibitor, steroid morpholate mTOR inhibitor. We can have a steroid morpholate with Belatacept. And second thing is like we can have a CNI withdrawal. So we can have like a early withdrawal or late withdrawal. Early means like less than 6 months, late means more than 6 months. And after withdrawal, we can keep the patient on like a steroid and morpholate, or we can keep the patient on steroid and mTOR inhibitor. But the most of the, I think there are a lot of trials, avoidance and withdrawal that has not gained much importance because of very high rejection rate. The third thing is like we can have a conversion. We can have a early or late conversion. So we can convert from CNI to non-CNI. So the most popular is to have mTOR inhibitor. So we can have a combination like a mTOR, morpholate, and corticosteroid. And third, the fourth thing is I think that is the most useful is like a CNI minimization, because all of the like data till that the most of data don't support non-CNI use. So I think we can try CNI minimizations. So we can target like a lesser CNI doses, and we can give the CNI in combination with like a morpholate and steroid. We can even replace morpholate with mTOR in combination with low dose CNI, because in the old patient it lead to less chance of rejection, rejection as well as less chance of infection like a CME and BKV. So I'm not going to discuss the most of trial. I'm going to discuss only few trials. The first is like an important molecule like a Belatacept. So basically it is like a fusion protein that bind with basically CD18 and CD86. So basically it will inhibit like a co-stimulation. So it will inhibit like a binding of T cell to the antigen presenting cells. So this is very specific, and it is like a non-CNI regimen. So that we have two studies. One of the like a benefit study, and another is a benefit extension study. So I am going to discuss benefit extension study, because it is the benefit extension study was in basically like a expanded criteria donor basically. So here like almost 69% were like a ECD donors, 10% were like a DCD donors, and 20% were like a donor with more than 24 ischemia time. So regimen they followed was like a basilicimab induction. And this is like a trial protocol. So what did they follow was to give like a repeated dose of like a Belatacept in one arm, and after the induction with like IL-2 blockers, and under the control arm we received like a standard cyclosporine regimens. So ultimately the aim was to have avoid basically CNI. So what the benefit extension study told was at the follow-up of like 84 months, like it is like pretty long follow-up, like 7 years. What they found was in the Belatacept arm there was a significantly higher GFR here. So it was like a GFR difference was almost 17 ml per minute per meter square at the 7 years. So it is like a big difference. So ultimately, and if you see like a long-term graph survival at like 84 months, 7 years, so it was not different. So ultimate, and if it's like a de novo DSA, that is the main worry after 1 year. So what the study told was the de novo DSA were list with the Belatacept arm, and it was pretty higher with basically cyclosporine arm. But if you see the rejection, there was like a trend of higher rejection rate at 36 months, 60 months, and 84 months. So this is like a biggest critic of Belatacept. They have high rejection rate. Ultimate conclusion of the Belatacept extension study was at the end of 7 years, the graphs are also pretty similar. But the problem is, the biggest problem with Belatacept is basically very high early rejection rate, and another thing is like a high risk of PTLD. But the biggest advantage is it will like offer you the CNI-free immunosuppression. So there is a less chance of nephrotoxicity, less chance of CV and metabolic risk of CNI will be not there. So the biggest critique of this study was the basically like control was not cyclosporine. It was not tacrolimus. It is a cyclosporine. Like right now, our practice like more than 70-80% patient is on the tacrolimus. And biggest critique, another critique was the induction was a declizumab. It was not like a ATG. So after the extension study, the NIH planned to have one CTOT 10 trial. In that this study they try to have like a LM2 induction and with like a Belatacept compared with the tacrolimus. But this trial was terminated very early because of very high risk of acute rejection in the Belatacept arm. So I think after this, the interest in the Belatacept has mainly waned basically. So now, like last 10-15 years, most of people have lost interest in the Belatacept. But we can like some people have suggested we can have like a different combination. So what we can do is we can give a LM2 ATG induction followed by Belatacept mTOR inhibitor. Or second concept may be like we can give tacrolimus for some time, like we can give tacrolimus for 6 months and subsequently withdraw to decrease the risk of acute rejection. And other thing is we can combine ATG injection with Belatacept and mTOR inhibitor. Basically the changes in strategies to basically decrease the risk of acute rejection. Second, the very important study is like a basically Elite Symphony study. What the study try to look at is that try to compare the low dose seromas with the like a standard or low dose cyclosporine versus low dose tacrolimus. What they found was the rejection were list with the low dose tacrolimus. It is much higher. It is in fact higher with the sirolimus. And if you see the like a graph survival was best with the tacrolimus. So if we offer like a non-CN regimen with the sirolimus, it has very high risk of acute rejection. But I think this study we cannot extrapolate to the older patient because the Elite Symphony study, the mean age of the like a recipient was like a 45 plus or minus 15 years, and mean age of donor was the same, like a 45 plus or minus 15 years. So we don't have that type of study that offer this the same protocol in the old patient, because the old patient will have somewhat less risk of rejection. So ultimately, we have like a lot of studies. I am not going into detail because the very few studies look into the like a older donor and older recipient. So we can have like a different CNI avoidance study, like a Symphony study, Orion study, benefit study. Ultimate conclusion of all CNI avoidance studies like a very high rate of acute rejection. So the CNI avoidance is the out of practice. The second thing is CNI withdrawal, like a Caesar study, Orion study. The conclusion of the trial is same, very high risk of acute rejection. So ultimately we cannot have a CNI avoidance, we can have like a CNI withdrawal. So I think we need to have like some sort of CNI. So I think the main theme, I think right now with the available literature is like it is a mainly CNI minimization. I think there we can have some advantage. So like a CNI minimization like with the Caesar, Elite, Opticept, Everest, Asset, they give some data. Well, minimization is important. It is like a preserve better the GFR, and it has somewhat like accepted rejection rate. CNI conversion is the data is also there. The main advantage is like it have a better GFR, less CME BK rejection, but this is mainly practiced in when we have like a confirmed CNI toxicity. So I think the if you see like everyone's common practice, no one practice like a CNI, whatever the donor age, whatever the recipient age, no one practice CNI withdrawal, no one practice conversion unless there is a documented CNI toxicity. So I think what we practice usually is like a CNI minimizations. Like what we can do is like if there is an old kidney or old donor, we can give like a lesser dose CNI dose from the beginning. We can have like early immunosuppression tapering, but we usually don't try to avoid CNA basically. So ultimately, what planning we can have, like we are dealing with the ECD kidney. So this same can apply with like a living aged kidney. So we can have an induction with the ATG basically. So there are a lot of data what to use, like induction with the basilism or ATG. I think induction with the ATG is better. It is supported by some of the trials. Second thing is we have to reduce the overall immunosuppression burden basically. It is more important, and it will, the net immunosuppression will decide how much infection the recipient have, because the most of the old kidney recipient will be like a most likely old kidney will go to mostly old recipients. So we have to reduce the overall net set of immunosuppression. We can try practice reduce CNI exposure. So we can give like a low dose of CNI. We can try to have like a lower trough levels. Even if the case has DGF, then we can have like a DNA CNI introduction also. And in some of the cases, we can try like a CNI reduction, or we can replace moflet with this moflet with the like mTOR inhibitors. So conclude my talk, CNI immunosuppression is still not suitable for the most of our patient, even when the donor is elderly. De novo CNI-free regimens are not recommended because the trial don't support that use, because it is met by the very high risk of rejection. CNI minimization may be used like giving like a less dose, targeting less immunosuppression, in particularly like an elderly recipient with low immune risk. And conversion to mTOR in some of the cases with CNI toxicity can be tried basically. Thank you.